to it earlier. So I started putting this talk together when I was a PGY2. Prior to that, I've added on. So basically, every slide, things more than once will start getting a bold and an underline and things like that. A little bit more time on the stuff that is. So for the junior residents, I fully recognize that this is sort of the proverbial drinking from the fire hose. But I think your residents, you're kind of the same talk with just a few updates. So after a couple run it, hopefully it'll start to stick a little bit more.
You're kind of in and out. I think according to Risa and Secris, it's not just me. Anything that you are aware of with your connection that might be iffy? We lost you completely.
Well, that didn't work well. Can y'all hear me again now?
Welcome back.
Wow. All right. Well, maybe I won't try the mobile hotspot. It didn't seem like that was quite the go-to. Is my audio better now? Hopefully.
Yeah, a lot better.
Yeah.
Okay. Well, I don't know what I did, but if it gets bad, just interrupt me and I'll go back through. So you can see this is just kind of showing you that over the last, whatever, 20-something years, where the questions used to be. And then as we went through, I started updating it. They switched it from a lot of soft tissue stuff to it moved into kind of bony work and more nerve stuff. And then it's really kind of, then it moved into replants and some different things. So as I mentioned, I'll try to highlight the stuff that's really come up more in the last few years. We'll start off with compressive neuropathies. I think this is really important to know in general, but it's been, some of it's been less discussed on OITE, but they've had a lot on carpal tunnel recently. So we'll go through kind of each one of these. Basically, this is not tested that much, but just as a background, remember the epineurium surrounds the outside of the nerve. The perineurium surrounds the fascicles. It's been asked in the past the smallest surgically identifiable unit, and that's the perineurium. The vascular supply runs in the perineurium. That was asked years ago. And then the endoneurium surrounds the individual axons. There's two types of threshold tests that really hasn't been asked much in a long time, so I'm not going to spend too much time. But there's thresholds that tests a single nerve fiber or group, and there's innervation density, which tests overlapping receptor fields. So you can remember your 2-point discrimination is innervation density. Your like monofilament and vibratory are threshold tests. I'm going to skip these basically because they haven't been asked in quite a long time, but there's 4 types of cells within the tips of the finger: Meissner's, Merkel's, Pacinian's, and Ruffini end organs. Super fast if people really want to know it. Meissner corpuscles are rapidly adapting, and when you do moving 2-point discrimination, that's what you're testing. They test innervation density. Merkel's are slowly adapting, static innervation density. And I got a little thing coming up that'll, if you want to get one take home, I'll show it to you. Pacinian corpuscles test rapidly adapting. They're for pressure sensation and light touch, and that's a threshold test. And Ruffini end organs are rapidly adapting sensory for threshold testing. So if you're going to learn anything, which again, I think this is more than you really need, I used to make this broad column. So the innervation density tests are on the left. The threshold tests are on the right, and if it's a slower, fast adapting cell, so you can see slowly adapting, testing innervation density, static 2-point, and that's the Merkel cell. Fast is moving 2-point, that's the Meissner. And then the thresholds, vibration, slow is the Ruffini end organs, and the Pacinian for the pressure and light touch. So a little thing we used to review that I don't think is as key. Phases of nerve compression, some of this has been tested, early, moderate, and severe, basically for all of your nerve compressions on OITE. If it seems mild, you're going to treat them conservatively, period. You're going to be looking for bracing and things like that. If it's moderate, then you're probably going to start thinking about surgery. And if it's severe, you're probably going to choose something that's like surgery, but they're going to have some permanent nerve damage. So mild carpal tunnel, they're going to give you normal nerve tests. Symptoms are intermittent. Positive provocative tests. What they've asked is, what's the pathology of the median nerve? And the answer is just edema. Treatment conservative. Injections, it's been asked, 80% of patients that have mild carpal tunnel, if you inject them, will get some positive response. Moderate carpal tunnel, now you're going to have positive nerve studies and maybe some early EMG changes. Symptoms go from transient to constant. The pathology is demyelination. So that's your buzzword for more of your moderate. And the treatment is typically going to be surgical decompression. Severe, you're going to have motor and sensory loss, positive nerve studies and EMG, and the buzz of pathology is endoneurial fibrosis. So again, edema, and then we're going to move to demyelination, and then endoneurial fibrosis and axonal loss. Treatment will be surgery, but the answer is going to include something about an incomplete recovery. Double crush means the same nerve is being hit at two different places. Classic ones include carpal tunnel and a C6 radiculopathy, or cubital tunnel and thoracic outlet. Think about those as both lower, kind of C8T1. The proposed mechanism of double crush is decreased axonal transport. In order, as you begin to compress a nerve, you're going to see these changes. The very first thing that's been asked in someone with carpal tunnel that you would see abnormal would be abnormal threshold testing, which again is monofilament and vibration. Then you'd lose static 2-point, then moving 2-point, then pain overall, then pressure, and then complete anesthesia. The other way to ask it is a patient has a complete nerve laceration. As that nerve recovers, what's the last thing that will normalize? And the arrow would just go the other way. So it'd be monofilament vibration threshold testing. Physiology of nerve compression, larger. So the motor nerves, if you remember, they're larger and they're myelinated versus the sensory nerves are smaller and they have less myelin. So when you think about nerve compression, which ones are more susceptible? It's going to be those sensory fibers. So that's why you typically see sensory changes sooner, and you'll typically see sensory EMG changes sooner. Speaking of EMG and nerve studies, here's the basics for OITE. The way you do the test is you stimulate the nerve from point A to point B, and you're measuring how long does it take the signal to get from point A to point B. As a nerve has, remember, moderate carpal tunnel demyelination, you lose that saltatory conduction where it can jump from node to node. Therefore, it takes longer to get from point A to point B. That's measured as increased latency on nerve studies. So if you see sensory latencies are prolonged or motor latencies are prolonged, that indicates demyelination. When you get to action potential, remember, action equals axon. Just remember that. So if you have the changes in the size of your compound motor action potential or your sensory nerve action potential, that means we now have axonal loss, which is obviously worse than simple demyelination. So action equals axon, increased latency is demyelination, and then amplitude of those action potentials is axonal loss. Also, a principle they like to test. Remember that the motor cells, bodies, live in the anterior horn cells of the spinal cord. The sensory nerve bodies live in the dorsal root ganglion, which is outside the spinal cord. So one thing they love to give you is a patient with a brachial plexus injury who comes in, they have an insensate limb with no motor, but they have normal sensory nerve action potentials. By definition, that's a root avulsion. Because what's happening when they stimulate that sensory, it can still have a reflex arc because the dorsal root ganglion is still in connection to the downstream nerve, if that makes sense. Uh-oh, frozen. There we go. EMG basics. Insertional activity is when you put the needle in and the muscle quivers a little bit. If you see increased insertional activity, that's abnormal. If you see polyphasics are good. Basically, everything else on EMG is bad, but polyphasics are good. So remember, polyphasics means muscle recovery. If they give you a patient that has a nerve injury, 3 months later, you get an EMG and you see polyphasics, how do you counsel the patient? It's that's good. We're seeing clinical recovery should be following those polyphasics. In contrast, fibrillations and sharp waves are bad and signify denervation. Now, fasciculations, if you remember tongue fasciculations, that when patients with ALS, that's a central problem. So if you see fasciculations on an EMG, you're thinking it's a neuromuscular disorder or a central problem. Places the median nerve can be compressed. Obviously the carpal tunnel, also in the forearm at the pronator, as it goes between the two heads of the pronator teres, or you can get isolated AIN palsies. Carpal tunnel has gotten a lot of questions, and these are basically all questions from the last several years. The most sensitive physical exam maneuver is the Durkin compression test, which is on the right, putting pressure and it reproduces their symptoms. Remember, the pathology is edema and fibrosis, not inflammation. The muscle that you should look for weakness in is the APB. That's also the most important muscle in opposition. Non-operative treatment for early stages should be used. Splints tend to help nighttime symptoms. Steroid injections are predictive of the results of surgery. And again, 80% will get at least transient relief from a steroid injection, and 22% will get 1 year relief. If conservative fails or they give you a more severe initial patient, you should consider surgery. The number one effect of surgery is relief of nighttime pain. Surgery's also been shown in last year's OITE to result in less paresthesias and better grip strength at 1 year. In terms of making the diagnosis, the CTS6 is sensitive and specific enough to be sufficient for the independent diagnosis of carpal tunnel. They haven't asked it yet, but ultrasound is also a sufficient means of diagnosing carpal tunnel, and nerve studies. So any of those would be reasonable. Antibiotics are not required for carpal tunnel surgery. That's been asked. And 10 pain pills is the recommended number of narcotic pain pills for carpal tunnel. Also, in the case of Guyons Canal entrapment, I just don't think I had a good place to put this. You'll see isolated motor weakness of the ulnar nerve, and they would want you to get an MRI scan to rule out a cyst in Guyons Canal. Sorry, I don't know. I don't know why that's in that one spot, but. They used to ask about carpal tunnel endoscopic versus open. Hasn't been asked in a while, so the highlights are equal long-term results, faster return to work for endoscopic. For both of these, the number one failure of carpal tunnel surgery, whether open or endoscopic, is incomplete release of the transverse carpal ligament. Pinch normalizes at 6 weeks, grip normalizes at 3 months. Internal neurolysis does not improve the results of carpal tunnel surgery, so don't choose that on your test. The volume increase of the carpal tunnel itself when you release it is 24%. Revision carpal tunnel surgeries, a quarter get complete relief, a quarter to half get no relief. Also asked before, where does the palmar cutaneous branch of the median nerve reside? And the answer is between the palmaris longus and the FCR. For those of you that think about it, when we do distal radius fractures, where do we go in relation to FCR? We go radial. Why is that? Not because we're scared we're going to hit the median nerve, because we can usually find it, but we're scared we're going to injure the palmar cutaneous branch. So that's where it lives. Pronator syndrome, proximal median nerve entrapment. And symptoms are going to give you basically a patient that shows up with carpal tunnel-like symptoms. But if they give you forearm pain or like FPL weakness, be thinking pronator syndrome. EMG will typically show changes in pronator quadratus and FPL, and they'll give you something like a Tenell's or tenderness in the proximal forearm. Your answer is going to be non-op, and if that fails, then you're going to release them with 80% success rates. Sites of compression of pronator have been asked. You can have a supracondylar process, which I'll show you a picture of in a minute. The ligament of Struthers, not to be confused with the arcade of Struthers, which compresses the ulnar nerve at the elbow. The lacertus has been asked. The deep head of the pronator teres, the origin of the FDS, and then also what's called Ganser's muscle, which is an accessory FPL. Those are all potential sites of compression of the median nerve in the proximal forearm. They'll give you they've given tests before, and if you just know those sites, you can figure out which one it is. So they give you resisted pronation of a flexed elbow. Think about you're firing your biceps, and you'd be looking for lacertus fibrosis on that one. Or if they gave it on an extended elbow, they'd want you to think pronator teres, because that's putting that one more on stretch. Middle finger PIP resisted flexion test, you'd be thinking the FDS origin. Here's just a picture of those different structures. There is the anconeus. The ligament of Struthers would come off of that supracondylar process, which is there. AIN syndrome will differ substantially from carpal tunnel or pronator syndrome because it's isolated motor. Remember, AIN doesn't have any sensory, so they'll give you an isolated motor loss of the FPL, FDP of the index, and normal sensation. EMG would be diagnostic. In your differential diagnosis would be Parsonage-Turner syndrome, but remember, those patients, you're going to get a history like viral illness, shoulder pain, then weakness. Then you're thinking Parsonage-Turner. Also, the differential would be a tendon rupture. FPL rupture is called Mannerfeld syndrome. It typically accompanies STT arthritis or rheumatoid. Remember, those people, when you do a tenodesis test, you won't have tenodesis because the tendon's been ruptured. For AIN syndrome, obs it for 3 to 6 months on OITE, and if it fails, you're going to release it. All right, hopefully y'all take 2 seconds and in your own mind figure out which side has an AIN palsy. Okay, hopefully you got it. It's the left side because, see, there's no FPL, there's no IP flexion of the thumb or DIP flexion of the index. Ulnar nerve compression. 2 sites you're going to think about are Cubital Tunnel and Guyons Canal. Be careful on the OITE. If they give you a patient that looks like ulnar nerve, but the exam there is normal, think about thoracic outlet or a Pancoast tumor, because remember, Pancoast tumor is an apical lung tumor. They should give you a history of smoking. That'll compress the lower part of the plexus, which is C8T1, and would be in your differential diagnosis. Another thing I'm not going over, but I just expect you guys, you have to know what muscles are innervated by each nerve, okay? That goes without saying. Another thing that I think is helpful on OITE, as soon as you start the OITE, I don't know if you still have a piece of paper or something you can write on, just draw the brachial plexus right out of the gates. And then just leave it there, because when you get to the brachial plexus questions, if you've already drawn it out, it's a lot easier than it is to try to think about it during the test. Cubital tunnel, numbness ring and small finger, the hand that seems clumsy. They should give you Tunnels at the elbow, decreased sensation. The dorsal cutaneous branch of the ulnar sensation differentiates it from Guyons Canal, because remember, the dorsal sensory branch takes off 6 centimeters proximal to the ulnar styloid. So they give you dorsal ulnar hand sensation is out. You know it's above Guyons Canal. Remember, Frohman's sign is where they pinch, recruiting their FPL more aggressively, and so they're going to have an IP flexion deformity when they pinch. The most common site of cubital tunnel compression is between the 2 heads of the FCU, is at what's known as the arcade of Struthers. Other things can be Osborne's ligament. An anconeus epitrochlearis is an unusual secondary muscle. A mass effect, snapping triceps of the medial head of the triceps, and cubitus valgus are all potential causes. There those are. Remember, arcade of Struthers, ulnar nerve, ligament of Struthers, median nerve. Non-operatively, you're going to want to put them in a splint in about 45 degrees of flexion. Anti-inflammatories initially. If that fails, surgery. The surgical questions that have now come up, there's plenty of studies showing in situ decompression gets the same result as anterior transposition. The exception would be if you have a nerve that they give you preoperative nerve or intraoperative nerve subluxation, then you'd be looking for transposition. Medial epicondylectomy is no longer required for these. 80 to 90% good results. Submuscular is what I would put on the test if they gave me a revision. Intrinsic atrophy has been shown to be a poor prognostic sign. The #1 complication of cubital tunnel surgery is injury to the medial antebrachial cutaneous nerve. And if they give you a patient that's had an elbow fracture, particularly if they had surgery and the patient's having symptoms of ulnar nerve post-op, they're going to want you to explore that nerve and release it. That was a couple of years ago. By the way, just so I'm going, I haven't heard anything. Is the volume doing okay? We're not having any more cutouts?
Doing great.
Good. All right. Guyons Canal, entrapment of the ulnar nerve. Again, normal dorsal ulnar sensory because that takeoff is proximal to Guyons Canal. The borders were asked a long time ago. It's been a while. Volar is the volar carpal ligaments, the roof, the transverse carpal ligaments, the floor, hook of the hamate radially, and pisiform ulnarly. The things, there's 3 zones, and it makes sense. As the nerve enters Guyons Canal, it's a mixed motor sensory nerve. Then in zone 2, the motor branch breaks off, and then at the end, you're left with just the sensory branch. So those are your 3 zones. It's been asked multiple times, the #1 cause of Guyons Canal entrapment, and the answer is a ganglion. If they wanted to get very specific, in zone 3, the #1 cause is ulnar artery thrombosis or hypothenar hammer syndrome. But overall, ganglion's the #1. There's Guyons Canal. Radial nerve. And one other thing they didn't put on, I didn't put on here, is cyclists will get Guyons Canal entrapment of their ulnar nerve. So if they give you a cyclist with things that sound like cubital tunnel, be thinking Guyons Canal. I'm not sure if that one's been asked or not. Radial nerve compression, the things to remember, you can have radial tunnel syndrome, which is different than PIN syndrome and Wartenberg syndrome. And then we'll talk a little about radial nerve with humerus fractures as well. Radial tunnel on the test is going to be a patient that sounds like tennis elbow, but it's too far distal. So it's pain only. Normal motor, normal sensory, normal EMG. Pain, but it's not over the lateral epicondyle. It's a few centimeters distal to it. Your answer is radial tunnel syndrome. The most common site of the compression is at the arcade of Frosch. And then there's also what's known as the leash of Henry, which is a little vascular leash, and then the tendinous portion of the supinator. Treatment is going to be non-op with therapy for a year. So for radial tunnel, give them a year with therapy on OITE before you consider surgery. Here's an example of it just to show you that clinically it is real. I think you can see this hourglass-like constriction of the nerve up top. And then once I release that supinator fascia, see how that nerve really perks up. So it is a real entity as well. PIN syndrome is very different than radial tunnel. PIN is isolated weakness of the PIN musculature. They don't tend to have any sensory component, and they may have some pain, but it's the weakness that's going to tip you off. They're going to give you an EMG that's positive. That's PIN, not radial tunnel. Watch them for 3 months, still not better, reasonable to decompress. One thing that gets asked too is how do you differentiate PIN syndrome from extensor tendon ruptures in a patient with like rheumatoid? And the difference would be the PIN syndrome patient would have normal tenodesis effect of the tendons, whereas a tendon rupture, you would no longer have your tenodesis. Now, Wartenberg syndrome is where you get entrapment of the superficial branch of the radial nerve, and it's been asked, where is that? It's right as it exits beneath BR and ECRL. So they're going to come in with numbness, like in the dorsal aspect of the first web space and dorsal radial hand, and some pain. Conservative treatment, remove a watch if they wear a watch there, decompress if that fails. Other random compressive neuropathies, suprascapular nerve entrapment can be either at the suprascapular notch, which remember it's got that transverse scapular ligament that the nerve goes under and the artery goes over. If it's there that it's pinched, you'll have weakness of the supra and infraspinatus, not very often tested. What is tested all the time is spinoglenoid notch cysts. Remember, those are going to be associated with a slap tear. They get a spinoglenoid notch cyst, present with isolated infraspinatus weakness, and it's usually going to be a volleyball player on the OITE. They give you a volleyball player, weakness with external rotation or isolated atrophy. Answer is spinoglenoid notch cyst, look for a slap tear, look for some sort of a scope to breed the tear and decompress the cyst answer. Thoracic outlet. Not tested as much, but just briefly, there's two types, neurogenic and vascular. They're typically going to give you a middle-aged female that comes in with these random complaints of some numbness and tingling, weakness, kind of a clumsy hand, normal exam, normal nerve study, and then hopefully they'll give you some tests like ADSINs or RUSs or tests that are specific for thoracic outlet. If it does come up and that is the diagnosis and non-operative treatment fails, the answer is a first rib resection. The other differential in that, if they give you that exact same patient and they said the ADSINs, the Wrights, the RUSs, and all those were negative in a middle-aged female, be thinking about MS. That would also be in your differential, so you'd be looking for an MRI of the brain on that one. Other ones that have shown up in the past, a neurapraxia, not a neuropraxia. A neurapraxia means the axons are intact. It's a demyelination only, and it will always recover. Versus grade 2, which is an axonomesis, now you've got damage to those axons and the endoneurial sheath is still intact. So the axons can still have the capability of recovering. These will have an advancing Tennels as they recover, and again on EMG you'll see polyphasics. Versus a neurotmesis means the whole thing's disrupted. The endoneurial sheath is disrupted, and so it can be either cut in half or it could be that just the perineurium's intact, but everything inside is ripped apart. It's been asked multiple times, the number one factor affecting nerve recovery is patient age. CRPS, two types. It has been asked a fair amount in the past. Type 1 is not associated with an identifiable event. Type 2 is. So if you have a distal radius fracture post-op, they have CRPS. That's a type 2 CRPS. The criteria I don't think is important. Things have been asked. A 3-phase bone scan is one way to objectively diagnose it. Early on, do not choose aggressive range of motion. You're going to look for answers that are like splint, gentle range of motion, desensitized, maybe a TENS unit. Also remember the old studies were vitamin C 1 gram daily after distal radius fractures can minimize the risk of CRPS. There's been other studies that have shown that's not effective, so I don't think they'd ask that anymore. And another thing that's come up is for phantom pain, which is different than CRPS, but I don't have anywhere else in this talk to put it, mirror therapy can be helpful. That's where they look in a mirror and they think they're looking at their good hand, but the mirror is showing, their mirror is showing them their good hand, and so they think they're looking at their bad hand, and their bad hand looks like a good hand, and it trains their brain into thinking that they're not having as much pain. Nerve repair. Elongation is bad. An 8% elongation results in a 46% rate decrease perfusion of that nerve. So, i.e., don't repair nerves under tension if that's a choice on OITE. Conduits for nerve repairs. What you're looking for on OITE is less than 2.5 centimeters. So if they give you a nerve gap that's less than 2.5 centimeters, then conduits can have an equal result to using nerve allograft or autograft. So 2.5 centimeters is the number. The questions on brachial plexus. One, like I said, draw it out so you can answer questions and figure out where in the plexus things have been injured. They like to ask questions about, do we think it's an avulsion, which is a preganglionic injury, or not? If you see a Horner's sign, think yes, particularly the lower root. C8 and T1 is where the sympathetic chain runs over. So a C8, T1 avulsion will typically have a Horner's sign. Meiosis, ptosis, and anhydrosis. Second would be if the rhomboids are out. If they give you absent rhomboid function, think preganglionic, because the takeoff of the dorsal scapular nerve is so high up on C5 that typically it goes only in the setting of a preganglionic avulsion. Also, if they give you positive EMG findings of the cervical paraspinals, highly suggestive of a preganglionic avulsion injury. When treating brachial plexus injuries, the #1 priority is elbow flexion. That comes up also in terms of when should you operate on a baby with an Erb's palsy. If they haven't gotten back biceps by between 3 to 5 months, that's what you're looking for. If they get it back before 3 months, they should make a near full recovery. Another question that was on this year's test, or last year's test, was a patient that has atraumatic shoulder pain, and then all of a sudden they start getting weakness in the arm. I told you earlier, Parsonage-Turner's in your differential diagnosis. The other term for Parsonage-Turner, which was, I think, silly of them, is neuralgic amyotrophy, which is the same thing as Parsonage-Turner. So if you get that viral illness especially, then shoulder pain, then loss of some function, be thinking Parsonage-Turner or neuralgic amyotrophy. There's the plexus. I'm not going to go over it. Just you got to know how to draw the brachial plexus. You have to know the nerves, and you have to know what each nerve innervates, period. Once you know that, it's pretty easy to figure out where in there's the injury once you know what things are out. All right, tendon injuries. We're going to start with the extensors, and we're going to work by zone. Any tendon injury on the OITE that's less than 50%, your answer is going to be early range of motion, no repair. There's 6 dorsal wrist compartments. You kind of need to know what those are. I think that's more basic than I'm going to spend time going through. The zones, just remember, the odds are over the joints. So zone 1, DIP, 3, PIP, 5, MP, 7, wrist. A lot to go into here. I'm not going to go through all the intrinsic anatomy of the hand. Some of the big pearls. You've got to know central slip is what extends the PIP joint. The lateral bands usually stay dorsal to the axis of rotation of the PIP. That's why your intrinsics are MP flexors and IP extenders. And the triangular ligament holds those lateral bands dorsal. That's important because to get a boutonniere, you need injury to the central slip and the triangular ligament, and that'll produce a boutonniere. Sagittal bands extend the MP joint. Terminal tendon extends the DIP joint. That's the biggest ones you need to know. Zone 1, which is the DIP. So it's just basically a mallet finger. So if you have a closed mallet finger, 6 weeks extension splinting, and then you'll go into a removable splint. Same thing with PIP. Closed central slip injury, 6 weeks immobilization of the PIP joint and extension. Same thing with sagittal band ruptures. If you have a sagittal band rupture, 6 weeks of the MP extension. So no matter what extensor tendon you get, that's closed, you're going to be looking for 6 weeks extension splinting of that particular joint. Bony mallets, you're going to treat them closed on OITE for the most part. Subluxation, it's mixed. There's data now that shows even with subluxation, they can still be treated closed. It's a little controversial, so I don't think they'll ask that. What they could ask is if you don't treat a mallet effectively, what deformity would you get over time? The answer is a swan neck deformity, which makes sense because what that means is if you can't extend your DIP, it's going to fall into flexion. Now, all the power of the extensor mechanism is going to concentrate at the PIP and lead to PIP hyperextension, DIP flexion, which is a swan neck deformity. I don't think they'll ask you to treat it, but for the seniors, just remember chronic supple mallet. The options would be a Sorrel procedure, which is spiral oblique retinacular ligament reconstruction if they gave you a more severe deformity, or a central slip tenotomy if they gave you a milder deformity. But the answer they've given you on a past year's test of what's the result of most mallets, it's a slight extensor lag without functional deficit. And that's true in real life and on the OIT. Zone 2, over the mid aspect of the middle phalanx. Again, more than 50%, fix it and splint them. Less than 50%, early range of motion. PIP joint. Like I said, to get a boutonniere, 3 things happen. Central slip has to go, then the triangular ligament has to go, and then the volar migration of the lateral bands is what will actually produce a boutonniere contracture. And so boutonniere is PIP flexion and DIP hyperextension. One test for testing an early boutonniere deformity. So how could you tell if someone hurt their central slip, but what if the triangular ligament was still intact and they'd still be able to flex and extend and they wouldn't have a boutonniere? So how do you test if the central slip was injured? It's a test called the Elson test. I don't know if y'all can see me or not on my screen, but I'll try to show you this. If you flex your PIPs and try to extend your DIPs, you notice you can't touch the tips of your fingernails together. If you had a central slip injury, that side would go straight because now you can't pull through your central slip. And so all the pull is through your terminal tendon. So your DIP joint would go into extension. So that's what the Elson test is. Block extension of P2, and they're actively trying to extend their PIP, and their DIP joint would go into rigid extension if they had a central slip injury. Otherwise, it's supple. You can do it on yourself. If you passively flex your PIP joint fully and try to extend against it, you'll notice your DIP is floppy. Treatment, again, splint that joint in extension, but leave the MP and DIPs free. If they gave you a avulsion fracture where you saw this big central slip avulsion on the OITE, I would fix it. If they gave you a chronic boutonniere, the answer is not, that was stiff. First, you'd have to get it supple with either therapy or releases or something, and then do a reconstruction. Another OIT question would be a volar PIP dislocation. By definition, injures the central slip. So if you see a volar PIP dislocation, be looking for a treatment of like reduce it and put the PIP in extension for 6 weeks. Or if it was unstable, fix the central slip. Or boutonniere would be a complication, things like that. Zone 4, same thing, less than 50%. Watch it, early range of motion, greater than 50%, fix it and splint it for 6 weeks in extension. MP joints, zone 5, things to watch. Any open wound over zone 5 is a presumed fight bite until proven otherwise. The treatment of a fight bite, I know in the ER, I have you guys just wash them out and put them on antibiotics. For OITE, the treatment is to the operating room for IND in the OR with admission for IV antibiotics. That's your board answer. Also in zone 5, sagittal band ruptures. Remember, sagittal band keeps your extensor tendon midline and extends your MP joint. Usually people injure their radial sagittal bands so that the tendon subluxates ulnarly like you see in picture F. See how that finger's falling ulnarly? So the radial sagittal band has been injured. What will happen is they'll give you a scenario where they can make a fist, and when they go to open it, they can't extend that digit. But when you put them in extension, they can maintain that position because then their extensor tendon is back reduced midline and it can hold it up there. Treatment, 6 weeks splinting and extension, leaving the PIP and DIPs free. Also, it's been tested twice now of boxer's knuckle. What that is, it can be a sagittal band rupture or it can be a dorsal capsular tear. Both of those are called a boxer's knuckle, but if you see boxer's knuckle, you're looking for sagittal band or dorsal capsular tear. You're usually going to treat it with splinting. How do you differentiate sagittal band ruptures from extensor tendon ruptures from PIN palsies? Sagittal band rupture, when you put them in extension, they can maintain it, but they can't actively get extension. So the other two, even when you put them there, if the tendon's ruptured, it'll just flop back down. If they have a nerve palsy, it'll just flop back down. Extensor tendon ruptures, remember, will not have a normal tenodesis, whereas nerve palsies will. So there's those things. Zone 6 and 7, same thing. Less than 50% early range of motion, greater than 50%, fix it and splint them. For any extensor tendon repairs, the #1 problem of surgery is extrinsic extensor tightness, which means they have a hard time making a fist because of adhesions and scar. Another thing that comes up all the time, non-displaced distal radius fracture, 2 months out, they feel a pop, they can't extend their thumb. Answer is an EPL rupture. Treatment is an EIP to EPL transfer. What's the most common tendon that ruptures distal radius fracture? EPL. What's the most common tendon to rupture with OIF of a distal radius fracture with a volar plate? F. If they give you that one, an FPL rupture, you're either going to choose an interpositional graft like palmaris into the defect or an FDS transfer. For sagittal band ruptures, or the treatment is emerging as opposed to just being an extension splint, is a type of splint called a yoke splint. Again, I don't know if y'all can see my video or my hand, but this is what a yoke splint looks like. It puts that digit in more extension so that they can continue to move without putting any undue stress on your repair. So yoke splint and early range of motion is going to be the best. Extrinsic tightness, like I said, that's just dorsal scar, so they can't flex good. And intrinsic tightness gets asked all the time. So intrinsic tightness is just the opposite. So in an intrinsic tightness test, let me do extrinsic first. So if you have extrinsic extensor tightness, then when I passively flex the MP joint down, because now the extensor's all scarred in, it's even tighter to try to passively flex the IP joints. Versus when I put the MP in extension, passive flexion of the PIP joint is easier. An intrinsic tightness test is the opposite. So when you extend the MPs, it's tight with passive PIP flexion. But when you flex the MPs, now you're taking the tension off of the intrinsics, and it's looser to flex the intrinsics. That's called the Bonnell intrinsic tightness test. If they gave you a patient with it, the answer would be intrinsic stretching or intrinsic release if that failed. Lumbrical Plus, they love it on OITE. You never see it in real life. Remember, the lumbrical comes off of the FDP and inserts into the lateral band. So it extends the IP joints and flexes the MP joints. What they're going to give you is a patient who had a DIP disarticulation, and all you did is just cut it off in the ER and send them home. Then they come back, and when they try to make a fist like this picture, they do MP flexion, but the PIP joint extends paradoxically. And that's called a lumbrical plus finger, because what's happening is when they're making a fist, their FDP, but the FDP doesn't have an insertion, but it's still attached to the lumbrical, which is flexing their MP and extending their PIP. So the answer would be release the lumbrical. The other time you'll see it in real life is if you do a 2-stage tendon grafting and you put in the tendon graft with the wrong tension, then the FDP can pull through the lumbrical and give you that. So that's the other scenario they could give you. In contrast, the exact opposite is, what if you over-tighten FDP for any reason? Remember, all the FDPs have a common muscle belly. So if you cut, say, your FDP to your middle finger and there's a section missing and I sewed it up and just hogged it together, now that FDP is shorter than all the other ones. So then when they go to make a fist, that one will bottom out first and use up all the excursion, so all the other fingers lag behind. The term quadriga comes from when Roman chariot drivers would have the reins for the 4 horses and they'd go through the little eyelet in the front. You can imagine they all need to be under the same tension so that when you pull to stop the horses, they all see the same force. If I gave you a short rein on one of them and you pulled, then that one horse is going to stop and all the other ones are going to keep running. So that's where the term comes from. Swan neck deformity, I mentioned earlier, that's DIP flexion and PIP joint hyperextension. Many causes, the most common of which is a mallet finger that's undertreated, but you can have it from other stuff like rheumatoid, FDS ruptures, CP. There's a lot of causes. You would just be looking for the individual cause to treat it on the OITE. Flexor tendons, so moving on. When they get injured, they heal in 3 phases: inflammatory, fibroblastic, and then remodeling. Tendon repair, this has been asked multiple times, is weakest at the 1 to 2 week post-op. So you can imagine it kind of sucks if you get somebody back and you splint them for 2 weeks and then you try to get them going with motion because that's the weakest point in your tendon repair. The goal of all the motion exercises that we do for flexor tendons is to limit adhesions. The one exception, that's actually 2 exceptions. If you have a child that's too young to be following instructions, then the answer on OITE is going to be, what do you do with a flexor tendon repair in a kid? The answer is going to be you cast them for 3 to 4 weeks. The other random group they could give you is someone like a schizophrenic, alcoholic person that you just really couldn't trust to do the exercises. You would cast them for 3 to 4 weeks. The cause of early failure in flexor tendons tends to be gap formation. If you see anything that's like gap formation 3 millimeters or greater, that's a recipe for disaster. The nutrition of a flexor tendon is synovial diffusion. That's the majority of its nutrition. We do have little vessels that come to it as well, called the vincula, but most of the nutrition is from synovial diffusion. That's been asked. What do you do with a partial tendon laceration? I already told you. If it's less than 50%, you want early range of motion. Now on the flexor side, remember they run through the flexor sheath. So if it's less than 50%, you might choose to debride the flap just to get better gliding and so they don't get a trigger finger from the flap of tissue. So on the extensor side, it's just leave it because there's nothing for it to get caught on. But on the flexor side, less than 50%, you're going to debride it. Greater than 50%, you're going to repair it with an epitendinous suture. If you do an epitendinous suture, remember that adds 20 to 40% of the strength of a standard repair. They've asked it multiple times, what's the #1 factor determining the strength of a flexor tendon repair? And the answer is the number of strands crossing the repair site. You need at least 4-strand repairs for active motion protocols. Remember, the A2 and the A4 pulleys are the 2 most important pulleys to prevent bowstringing in the fingers, and the oblique pulley is the most important one in the thumb. There are studies now showing you can release A4 if you have to get a good repair on flexor tendons, and you can release up to half of A2. Passive motion protocols. You repair flexor tendons, and we're going to splint them and then begin a passive motion protocol. What position do you put them in? 30 degrees of wrist flexion, 70 degrees of MP flexion. As opposed to active motion protocols where the wrist is in 30 degrees of extension. It makes sense, and I'll show you how you can remember that. Put your own wrist in full flexion and make a fist. You'll notice that's very uncomfortable and you feel a lot of tightness. That's because that's a lot of load when your wrist is flexed. Do active motion. Now put your wrist in 30 degrees of extension and do active protocol, and it's very comfortable. So active is in wrist extension. Passive is with the wrist inflection because you don't want to extend the repair by putting it in extension for the passive protocols. Other thing that's been asked, what's the best way to assess the quality of your repair? The answer is to do the surgery under local anesthesia. So that Wallant that Geary gave us grand rounds on a while back. The zones of flexor tendons. Zone 1 is where there's only 1 tendon. So it's distal to the FDS insertion. Zone 2 is where there's 2 tendons in the flexor sheath. So it's from the A1 pulley to the insertion of the FDS. Zone 3 is between the A1 pulley and the distal edge of the transverse carpal ligament. Zone 4 is in carpal tunnel. Zone 5 is proximal to that. As I already told you, remember A2 and A4 are the important pulleys for preventing bowstringing of the tendons. Oblique pulley is the most important for the thumb. Zone 1 FDP injuries, again, distal FDS insertion. If you advance the stump too far, you can give them quadriga. We already talked about that. The #1 complication of an FDP repair in zone 1 is a DIP flexion contracture. The Leddy-Packer classification, you need to know it when you're on hand. You don't really need to know it for the OITE. Just remember, if the tendon retracts all the way back to the palm, you need to fix it soon. If the tendon pulls off with a big chunk of bone, it's way out there at like A4, you've got more time to fix those. The way you test this is a tenodesis test, which again means you passively flex their wrist, their fingers should extend. As you passively extend their wrist, their fingers should flex. So you would see the DIP joint not moving with the tenodesis test. Zone 2, flexor tendon repairs. That's in the pulley system. The goal is obviously to get active motion protocol. Things that have been asked before. If you have too much bulk and it doesn't glide good, what's the next step? It's to resect 1 slip of the FDS. That debulks it so it can glide better. What's the best way to assess the tendon gliding and the quality of your repair? I already told you, wide awake surgery is the answer for that. Zone 4, the only thing interesting about that, if you get a question in Zone 4 about a flexor tendon repair, what's weird is the answer is to repair the transverse carpal ligament in a lengthened fashion. So it's the only time you actually fix the transverse carpal ligament, and it's to prevent bowstringing of the tendons at that level. So it'd be Z-lengthen and repair transverse carpal ligament. Of the thumb, so FPL lacerations, you want to preserve that oblique pulley because, again, that's the most important one for the thumb. Re-rupture rates are higher. You can see 15 to 20% compared to tendons, which is much lower. And risk of prominent volar plate. I don't remember what that was about. There was some question about that. Must be something, if you had a laceration and went through the FPL and included the volar plate, probably a higher risk of complications with that. Flexor tendon grafting. So when would you do a 2-stage? If they give you a scenario where flexor tendons have been cut and it's like weeks out or months out, and they say it's tons of scar and things like that, then the answer is going to be put in a silicone rod, stage 1, and recreate the important pulleys, which are A2 and A4. Then you go back and trade out the rod for a tendon graft. If they ask you about which graft, intrasynovial grafts such as toe flexors have less adhesions than extrasynovial grafts such as palmaris longus. 50% of these require yet a third surgery for subsequent tenolysis. All right, moving on, soft tissue problems. Nail beds. If they give you a subungual hematoma nowadays on the test, the answer is going to be leave it alone or trephinate it, which is just putting a little hole in it so the blood can get out and be less painful. If they give you a subungual hematoma with a fracture that's displaced like this, then the answer is going to be take off the nail plate, repair the nail bed, and reduce the fracture. This is a particular tricky fracture called a Seymour fracture, and it's in children, and this is a transphyseal fracture. Danger is if you just reduce this closed, the nail bed can get entrapped, and they have a higher risk of infection. So this should be a surgical procedure on OITE. If they're missing nail bed and that's a problem, you can do a split thickness nail bed transfer from a toe or an adjacent digit. Fingertip amputations on OITE. I already gave you guys that fingertip talk earlier. They really don't ask a lot about this except these questions. If it's less than 1 centimeter and there's no exposed bone, the answer is secondary intention. Just watch it. These do heal good. You can see the picture at the top. If they give you a really young kid, 1 or 2 years old, cuts the end of their finger off like this, what do? You just sew it back on without micro. It can just be a composite graft, and that's all that you would choose. The other flaps I'm going to get to coming up. You're not going to choose a skin graft on OITE for a fingertip injury. You might choose a VY. This is going to be one where they give you a transverse or a dorsal oblique amputation that you might choose to do a VY advancement flap to cover that up with. When a VY, the nice thing is too, you can do that on any of the fingers. A Moberg, if they give you any thumb amputation on the OITE that's transverse or palmar, look for Moberg advancement flap. That's what they're going to be looking for, and that's what this looks like here. You're going to advance it to cover up the end of the thumb. Now, if they give you a dorsal wound, like back here on the IP joint, you can't just wrap this all the way around the end of the thumb. So dorsally, you would not choose this, but any transverse or palmar, be looking for it. Unless they gave you a thumb that was less than 1 square centimeter with no exposed bone, then it would be secondary intention. Cross finger flap. This would be a good one if they give you, now you wouldn't want to do this for the middle finger because it's longer than the other digits. It works best for like index, ring, and small because you can go cross to the finger that's longer. And this would be used for volar oblique or transverse amputations. You can also do a reverse cross finger flap. So this is a normal cross finger flap here. So we're borrowing from the back of one finger to cover the palm of another digit. And you can also cover the volar aspect like right here over P2. So you can imagine we could raise this off of this digit to cover right here, and that's been asked. Other things, a reverse cross finger would be a weird scenario where you need to cover back here on a digit. You can do basically raise the skin like a cross finger from this finger, but then take the fat and the sub-Q tissue to cover up the other digit and then put a skin graft on it. So that's been asked. Is the only reason I highlight that. Thenar flap. This is it. You're going to sew that digit into the skin at the base of the thumb. Contraindications are older patients because they'll get too stiff. The best fingers are the index and middle fingers because it's hard like to reach your pinky finger all the way over there. Advantages versus cross finger flaps is there's no dorsal scar. And again, the number one complication is a PIP flexion contracture. Thumb coverage. I already told you, look for a Moberg flap for anything transverse or palmar, unless it's less than a centimeter. If it's dorsal, I would look for what's called a kite flap, which is also called the first dorsal metacarpal artery flap, or FDMA flap, because that's the artery that perfuses the skin on the dorsal aspect of the proximal phalanx of the index finger. So that's what you're going to use for dorsal thumb, especially over the dorsal aspect of the IP joint. They could ask you, you can also make that a sensate flap, because you can take the superficial branch of the radial nerve that goes to that and sew it into the digital nerve on the thumb. If they give you a completely degloved thumb, like totally, like if there's no skin circumferential, your answer is going to be a groin flap. Blood supply for a groin flap is the SCIA, the superior circumflex iliac artery. If they give you an amputation of the thumb and now it's healed, but it's short and it's kind of proximal phalanx or metacarpal level, you can look for metacarpal lengthening. Toe transfer is also an option. And if it's way down at the CMC joint, you're either going to do a toe transfer or an index pollicization. Something they used to like to ask, I don't know because I haven't asked you guys whether or not they've asked this recently, but it used to be, what do you do to cover an open tibia? Proximal third gets a gastroc flap. Middle third gets a soleus. Distal third, it used to be a free flap, although now they might ask you a sural artery perforator flap. Any of those would be reasonable choices. 1 year, my last year, I thought it was a BS question. They gave you a crush injury to the tibia with an open middle third tibia fracture. What's the treatment of choice? And I put soleus flap, and they wanted you to do free flap because you were supposed to infer the fact that because it was a crush injury, the soleus is probably damaged. So just be careful for things like that. Other flap pearls, when you do a Z-plasty, a two-tailed Z-plasty gives you, so a 60-degree angle gives you 75% increase in length. That's been asked. If you really want to get down to it, and probably for the Chiefs, before you take your actual boards, I would just write these down and learn it the night before for boards. If you're someone who wants to go from the 99th to the 100th% on OITE, you can memorize these as well. The lateral arm flap, the blood supplies the posterior radial collateral artery. Medial arm flap, superior ulnar collateral artery. Groin flap, already told you, superior circumflex iliac artery. It's also been asked what nerve is at risk when harvesting a groin flap, and it's lateral femoral cutaneous nerve, which obviously makes sense. Just think about where you are. And then the lat flap was asked last year, what's the blood supply for a lat flap, and it's the thoracodorsal artery. Replants. When on, this isn't what we do in real life always, but when on OITE and boards do you replant a digit? Child, thumb, multiple fingers, wrist or proximal, or this is the one they always love, individual digit distal to the FDS insertion. We don't do that much here, but that is an actual board indication. Timing for digits, less than 12 hours of warm ischemia time, less than 24 hours of cold ischemia time. For major limb, less than 6 and less than 12. How do you handle the replantable part? It's rapid and moist gauze. Put that in a bag, and then the bag goes on regular ice, not dry ice. They haven't asked in a long time the sequence of things that you repair, so I'm not going to cover that. Monitoring it, they might ask you this. If you did a replant and post-op, and this is good just to know for in general, if you get a call to the floor that the replant's not looking good, the first thing you do is loosen the dressings. The next thing you do is pop a few stitches. And then things like heparin, leeches would be indicated if it's a venous outflow problem. If it's an arterial inflow problem, they're going to either need heparin or return to the operating room to redo the anastomosis. Number one cause of replant failures are venous. They say arterial thrombosis. That was on the OIT a long time ago. More often, honestly, now it's venous thrombosis. So I would really be looking more for venous. Leeches have been asked. How do they work? They secrete something called hirudin, which is what makes the anticoagulant so that the blood can come out. What bug are you at risk for contracting an infection from while leeching a patient? The answer is Aeromonas hydrophilia. What's the treatment of choice to prevent an Aeromonas infection? Fluoroquinolone. What if it's a kid or someone with allergies to fluoroquinolones? The answer is Bactrim. So leeches, hirudin, Aeromonas, fluoroquinolone, Bactrim. Most common secondary surgery after a replant's tenolysis. Major limbs, if they end up with myoglobinuria, they can end up in kidney failure where you have to take it back off. An absolutely absurd question from several years ago is what's the role of allopurinol in post-replant? And it's that it was recommended to decrease xanthine production. You can just put that little nugget in your pipe and smoke it. That's a ridiculous question, but. All right, ring avulsions. For OITE, what you need to know is this cutoff right here. If you have a ring avulsion injury, but there's no tendon or bone injury, we're going to fix it. If you get a complete degloving, like a picture like this, the answer is amputation, not replant. If you salvage a ring avulsion, the number one complication is cold intolerance. If you do central ray amputations, which usually, obviously, it's the ring finger, they're going to want you to consider transposing the adjacent digit to close down that space and improve their function. All right, moving on to vascular disorders. Volkmann's ischemic contractures. Remember, the deep muscle groups are going to be the ones that are primarily affected. So just think in a forearm, what muscles are the deepest? FPL, FDP. Those are going to be the most severely involved. Early on, they're going to want you to release the contracture and excise any muscle that's clearly dead. Late, they're going to want you to lengthen muscles or transfer muscles, or conceivably do a free gracilis transfer if you're really missing a lot of muscle. Berger's disease, if you have any questions about Berger's disease on OITE, the answer is they have to stop smoking, period. Vaso-occlusive disorders can be arterial, they can be emboli, systemic disease. They're going to give you a patient with claudication, paresthesias, cold intolerance. And remember, vaso-occlusive diseases tend to be unilateral, vasospastic diseases tend to be bilateral. So vaso-occlusive diseases, the number one vaso-occlusive disease in the upper limb is hypothenar-Hammer syndrome. And that, again, is ulnar artery thrombosis at the level of Guyons Canal. They might give you a patient that sounds cubital tunnel-like. Ring and small fingers are kind of numb and tingly. They have some pain. They're going to give you pain in their palm or something like that. The questions that have come up is what's the best test for diagnosing hypothenar-Hammer syndrome was asked, and the answer was arteriogram. They then asked, what's the best, they also said non-invasive vascular studies are an okay first-line screening test a couple of years later. So I really don't know what to tell you on that. It's very conflicting. Answer of what do you do about it? Surgically, it's going to be thrombectomy, sympathectomy, and or vein grafting. So if you have a bad disease section of it, you're going to cut it out and vein graft it. Embolic disease to the hand, 70% are cardiac in origin. Find some test answer that's work up their heart, heparin or streptokinase, maybe if it's very early on. Aneurysms, remember, true aneurysms are fusiform vessel expansion versus false aneurysms, which form from penetrating trauma. So if you get a stab wound to the wrist and they have it, it's going to be a false aneurysm. The answer is going to be excise that aneurysm and they either repair or graft the existing defect. Frostbite. The answer you're going to be looking for is rapid rewarming at 40 to 45 degrees of Celsius. If they give you digits that are dying from frostbite, the answer is do not amputate early, ride it out so it fully demarcates. Currently, the recommendation is not to anticoagulate, although that has gone back and forth in the past. They've asked before, what do you do with blisters and frostbite? I don't know what to tell you. One year the answer was to debride them. The other year the answer was to leave them. So hopefully they don't ask it. If they ask it, we'll update the talk because so far they've been two and they've given you both answers. Raynaud's phenomenon is just episodic ischemia and acrocyanosis. Raynaud's syndrome is the phenomenon that's secondary to some disease process. Raynaud's are going to give you a young woman. It's going to be bilateral, intermittent hand discolorations, answers of what to do. Avoid cold, stop smoking, calcium channel blockers, aspirin, thermal biofeedback, topical nitrites was last year's, and then a sympathectomy is your surgical option if that fails. 2016, they also gave you what I think is a very reasonable answer is Botox. So a non-surgical next line. So I think I would be looking for smoking, avoiding cold as your first line. Then if they gave you medicines, last year they said topical nitrites is number one. So I think I would look for that as my number one topical thing. Then calcium channel blockers, they want you to take it to the next level. Then I'd be looking for Botox. Then I'd be looking for sympathectomy. Hand infections. Paronychias. What do you need to know? The most common organism, Staph aureus. The treatment is IND and antibiotics. If they give you a chronic perinicular infection or a chronic epinicular abscess, particularly if they give you like a dishwasher or someone whose hands get wet all the time, think fungal, so Candida albicans. The answer you're looking for on that is marsupialization, which is where you cut out this little smiley face. Fluid can egress from underneath the epinicular fold. It'll dry up and heal. Also, remember, anytime you have an infection that's not healing, it won't get better, biopsy to rule out a Marjolins ulcer or squamous cell carcinoma, which I just had a case 2 weeks ago, actually. Felons, Staph aureus, IND, and antibiotics have to break up the septae when you do it. Also, it's been asked to avoid a mid-axial incision, which makes sense because that's where the nerves are and you're more likely. So you're going to, even if it's more swollen there, they're going to want a midline incision as opposed to a mid-axial incision. Flexor tenosynovitis. Hopefully you all know the canaval signs. Most commonly it's staph. On the OITE, the answer is IND in the operating room and admit it for antibiotics. Now, sometimes in real life, if it's early, we'll try admitting them for elevation antibiotics, but not on OITE. Just like a fight bite, go to the OR, wash it out. Remember, flexor tenosynovitis of the thumb or of the small finger can lead to horseshoe abscesses through Perona's space, which is that space connecting them. Another thing that's an interesting one, remember, flexor tenosynovitis of the index finger drains into what space? The answer is the thenar space. That's a little confusing. Septic arthritis questions, fight bites, we already talked about. IND and IV antibiotics, the causative organisms are alpha strep and staph. And also remember Eikenella corrodens, which is a gram-negative rod commonly found in the human mouth flora. For that, you're going to add penicillin. Bacteroides is the most common anaerobic septic arthritis. Treatment is unison or augmentin. And then a collar button abscess has been asked. They're going to show you an infection between two fingers, like at the metacarpal head level, and it's going to look like the fingers are abducted away from each other. They're going to want you to do an IND through both a combined volar and dorsal approach, and then IV antibiotics. Cat bite, alpha strep's the most common. Pasteurella is the classic answer, though on one of the OITEs, they said Pasteurella is the most common. So again, one of those mixed messages. If they give you a marine environment, Mycobacterium marinum is what you're looking for. And remember, that has to be cultured on 30-degree Lowenstein-Jensen medium. If they give you a rose thorn, Sporotrichosis shinkai, it used to be treatment was potassium iodine. Now the treatment is the oh shoot, what's the name of those antifungal medicines? The I keep wanting to say losartan, but it's not. It'll come to me. The classic just
Conazole.
Yeah, the conazole, itraconazole. Thank you. So itraconazole is what you're gonna be looking for Sporotric. Look at this picture and just remember, that's not an infection. That's herpetic whitlow. When you see these little white vesicles, herpetic whitlow, they're usually going to give you either a child or a healthcare worker. Answers observation. If they gave you a really bad case in a kid, you could consider ganciclovir or acyclovir because there's a small risk of herpetic encephalopathy. Other simulators of infection, they may give you a calcified meniscus or a calcified TFCC. Remember, that's when you're thinking of pseudo-gout or CPPD. Okay, Gary just logged on and said things are going well. Thought it was something important that he couldn't hear me or something, but we're all good. Calcific tendinitis, the place they'll give you this, they'll give you a red swollen wrist directly over the FCU, and that can be calcific FCU tendinitis. Treatment would just be anti-inflammatories or steroids. Factitious illnesses, look at this picture on the bottom and remember this. They're going to give you a picture of somebody and they're going to give you a history that they've got like Crohn's disease or ulcerative colitis. This is pyoderma gangrenosum. Treatment would be steroids. They might want you to biopsy it to prove it, but the treatment would be steroids. Also remember, any high pressure injection injury, the answer is surgery. They're going to go get washed out. Neck fash, causative organisms, group A strep or Clostridia, 32% mortality, even higher in immunocompromised patient. Obviously, the answer is emergent IND and or amputation. All right, finger fractures or dislocations. PIP dislocations, I already told you, volar dislocations are uncommon, but what do they by definition have injury to? Central slip. Can result in boutonniere. Dorsal dislocations are the most common and just need a closed reduction. Rotatory dislocations have two planes that are involved, and usually it's just a third type. They typically still can be close reduced. So dorsal dislocations, close reduce them and then buddy tape them and let them work on range of motion immediately if they're stable. If they're still unstable, you would put them in an extension block splint temporarily. If anything's open on OITE, you take it to the operating room. PIP dislocations, I already told you, volar central slip. Rotatory, oh, this has been asked. Rotatory can get snared where it's not reducible. And the reason is the condyle of the head of P1 buttonholes between the lateral band and the central slip. And that's been asked before. PIP fracture dislocations. These you've seen a lot of on the OITE. If the amount of articular surface is less than 30%, then it should be stable and your treatment is a dorsal blocking splint and early range of motion. They shouldn't ask you about 30 to 50%. If it's more than 50%, it's by definition unstable and needs something done. What's the radiographic sign of instability? It's what's called the V sign, which you see here, a V back here as opposed to being congruent. What about if it's just pulverized, like a pilon fracture, where palmarly and dorsally it's pulverized? The answer is going to be a dynamic X-fix. So just be looking for some sort of an X-fix if that's the case. All you need is the joint to be congruently reduced. You're not worried about piecing together all the articular fragments. One other thing I was going to see if it would come up not. If they give you one of these and it's like 6 weeks out, or you get in there and the volar lip looks terrible, look for hemihamate autograft. I think that's far enough along now where that could easily be a test answer now. Finger fractures, #1 problem and #1 indication for surgery is malrotation. You always want fingers to move by 3 to 4 weeks. When should you choose surgery? It's tough because they go all over with these, but things to think about if you see unstable, displaced intraarticular, open, polytrauma, multiple fractures, and it changed. Last year, they gave you a gunshot wound and wanted you to take that to the operating room for an IND, which that's a change. Historically, low velocity gunshot wounds anywhere could be considered more closed and didn't need urgent surgical debridement. But last year, they put that on there, and it wasn't like a rifle. So I guess currently we're leaning towards IND even for gunshot wounds. Most fractures you can pin. If they give you long oblique fractures, then interfragmentary screw fixation is reasonable, particularly if the obliquity is more than 2 to 3 times the length of the fracture. I'm sorry, the diameter of the medullary canal. Seymour fractures I talked about, that was that distal phalanx fracture where it came through the physis. Remember, the nail bed can be incarcerated, IND, and reduce it. There it is. There's the little nail bed getting fixed. MP dislocations, they're going to want you to try a reduction first. If the reduction fails, then it needs surgery. Remember, what's blocking it from getting reduced? The volar plate. So interposed volar plate is the problem. Surgical approaches. Dorsal has less risk than neurovascular bundle. Volar is the structure at risk with the volar approach to the MP joint when it's dislocated is the radial digital nerve. That's been asked 2 or 3 different times. Gamekeeper's thumb, ulnar collateral ligament injury to the thumb MP joint. If there's no Stenner lesion and it's an incomplete injury, the answer is going to be cast. If they give you a Stenner lesion or a palpable nodule on the ulnar side of the thumb, the answer is going to be surgery because the ligament is trapped by the adductor aponeurosis. That's been asked multiple times. So Stenner lesion, UCL stuck behind the adductor aponeurosis, needs surgery. Otherwise, for the most part, you can cast these. Thumb base fractures. Bennett's fracture, what's been asked on OITE is the #1 deforming force is the APL. And you can see that's what pulls it proximally and makes it want to dislocate. The adductor is a secondary deformity. Treatment's going to be CRPP versus ORIF. If you have more than 1 millimeter of articular step-off, they'll eventually end up with arthritis, although clinically it's usually well tolerated. What is attached to the Bennett's fragment? The answer is the anterior oblique ligament, also known as the beak ligament or the AOL. That used to also be the answer to what's the most important stabilizer of the thumb CMC joint. That is no longer the answer. The answer to that would be the dorsal ligament complex or the dorsal radial ligaments. A Rolando's fracture is just a comminuted fracture at the base of the thumb metacarpal. They're going to want you to do ORIF or X-fix. Thumb CMC dislocations, these are very unstable injuries. Again, the big important thing about this, what's the primary stabilizer? That dorsal radial ligament complex. What are you going to do on OITE? You're not going to just cast it because that's going to be insufficient stability. They're going to want you to at least pin it and or do a ligament reconstruction. Baby Bennett fracture. What's important about this is they like to ask, what's the deforming force? The answer is the ECU. Remember that inserts in the base of the fifth, and that's pulling this fracture and shortening it. What view do you get to see this? A 30-degree pronated lateral. 30% if 30% or more of the dorsal hamate is involved, then that needs to be fixed as well. Another question I shouldn't have anywhere to put it is metacarpal fractures. For every 7 degrees, for every 2 millimeters of shortening, you have a 7-degree extensor lag. That's been asked in the past. All right, pause. Everybody get a sip, or at least I need a sip. All right, wrist pain. We're going to take these by quadrants of the wrist. So we're going to start with radial-sided wrist pain. We're thinking about intersections, de Quervain veins, scaphoid fracture, slack and snack wrist, STT arthritis, FCR tendonitis, volar ganglions, thumb CMC arthritis. Another one that I didn't have anywhere else to put it is gymnast's wrist. When gymnasts come in, they hurt right over their physis. It was asked in the past, where is that involved? And it's the zone of provisional calcification. And then remember your wrist ligament. They've also asked, what are the extrinsic wrist ligaments? Remember, radioscaphocapitate, long and short radial lunate palmarly are your big ones coming off of the radius. Intersection syndrome. This is going to look like de Quervain veins on the OITE, but it's going to be more proximal. It's going to be at the intersection of the first and second compartment. They very often will give you a rower on your exam. It's also been called rower's wrist. They'll give you audible or palpable crepitance. That's how you absolutely know it's intersection syndrome. Treatment, splint, anti-inflammatories, injection. Don't look for surgery unless it's a failed case. De Quervain veins tend over the first dorsal compartment, pain with a Finkelstein test. Oftentimes they'll give you a new mom or a housekeeper, same treatment, splint, injection, anti-inflammatories. If it comes to surgery, remember most people have a separate EPB subsheath. That has been asked. If you do surgery, remember to release along the dorsal edge of the first compartment to prevent volar subluxation of the first dorsal compartment tendons after release. That's been asked. Scaphoid fracture questions. Remember, the blood supply comes in from distal to proximal, which makes it vulnerable to AVN. AVN, proximal fifth of the scaphoid, they're almost 100%. Proximal third, already 30%. Remember, for scaphoid fracture, someone comes in with tenderness in the anatomic snuff box and normal x-rays, the answer is going to be one of two things. Either splint them and follow up in 2 weeks for repeat radiographs, or an immediate or an MRI early if you need early detection. They've asked both those in the past. 2/3 of these are waist fractures. Surgical indications. Basically, if it's displaced at all, it gets surgery. If it's a non-displaced, very proximal pole fracture, it gets surgery. Pearls about the approaches. Volar approach, safer with respect to the blood supply and works better for waist and distal thirds. Think about it. Palmarly, you can feel the distal pole of your scaphoid. Dorsal approach is better for proximal fractures, but has a higher risk of injury to the blood supply and equivalent clinical results. When on OITE should you consider a percutaneous screw for a non-displaced fracture? What has it been shown? Faster healing, faster return to work, similar costs to casting because of how long they cast if you count in out of work factors for that. When should you do a vascularized bone graft on OITE? The answer is going to be if it's displaced, non-union, with AVN, without arthritis. That's what you're looking for. There's a chance they're going to push you guys towards an MFC, which is a vascularized medial femoral condyle graft. At least I used to showed up on the 2016 test. So if they're looking for a choice of vascularized grafts, consider that. The other thing they could give you now is AVN of the proximal scaphoid, non-union in a really young patient, and the cartilage is bad on the proximal scaphoid, but everything else looks good. There's something called an MFT, which is a vascularized medial femoral trochlear graft, which incorporates cartilage to replace the proximal pole width. So I think that's probably becoming fair game now too. They asked in the past, what's the first place you get arthritis with a slack wrist? And the answer is the styloid and scaphoid.
Dr. Gaston, is all this on a slide? Because right now we're still seeing the original scaphoid fracture slide. Hello.
I'm seeing the same thing you are, Randy.
I think we've lost you again, Dr. Gaston.
I will text him to see if he can hear us. Dr. Gaston, can you hear us?
Hey, I just spoke with Gaston. He's signing out and signing back in.
Thank you.
No, not that one. So, go get the flashlight from inside the house.
Am I back?
You're back.
Welcome
Back. Thanks, team. I figured everybody needed a break. That was a lot to process, so we were just going to take a little pause there, get me back in the game. Hello. Fuck.
It looks like your slides are still not advancing, Dr. Gaston.
Okay, but you can. I didn't hear anything. Just making sure you could see it. Do you see me there on scaphoid non-union snack?
No, it still is the initial scaphoid fracture slide.
What in the world? Now does it say STT arthritis, or it's still staying there?
I
Still
still
there.
see the same.
Oh my god, how weird! Mine is changing and y'all's isn't.
We never lost your share screen even when you logged off and on, which is
Weird.
so
Can you
it's a
see
little
that?
strange. It's still just that same scaphoid fracture.
Oh, y'all are
slide.
just on that slide. It's like I'm on like my home screen and stuff.
Mhm.
Is there a weird?
Maybe try
I'll hit stop
stopping
sharing.
sharing your screen and reshare it.
Yeah, mine says I've stopped sharing. Can y'all see me now like normal?
Interesting. You're still sharing.
Olivia, can you try sharing your screen for a minute and see if it'll somehow kick the system into action to?
I've been trying to share my screen for the past few seconds. Not working.
You know what's funny? When you just shared your screen, I saw my scaphoid slide.
Yeah.
Even though I can't see it on my own computer.
Yeah, I started the meeting, so I just tried sharing my screen and now I'm stopping. I think now maybe try it.
Okay. Let me go back.
Yeah, we no longer at least see that scaphoid slide.
Ah, it's a hell of a slide. At least we had that going for us.
Spectacular.
All right. Now do you see like my overall stuff?
Yep.
We're good. Yep.
Yeah. Now we're back. You got the snack slide?
Snack.
Yep.
Snack time.
All right. Well, hopefully everybody else got a little snack in right then. It was good times for me. All right. So styloscaphoids is the first stage of slack wrist. And we talked about the other stuff. Let's see. Okay. Yeah. So in determining is it AVN or not, the best predictor is punctate bleeding at the time of surgery. Again, I think they're going to want your indication for vascularized graft to be a displaced non-union with AVN. STT arthritis, it's the second most common wrist arthritis. The answer, they're going to give you two choices. They're either going to give you a CMC arthroplasty or an STT fusion. Less common, obviously, to do STT fusions. In general, just as a pearl for OITE, when you see things like a laborer, think about fusions a little bit. That's usually on OIT when they're pointing you to something that they want to hold up to the test of time. CMC arthritis, the things that have been asked, the two views, a hyperpronated PA and a true lateral view has been asked. They really haven't asked much about the classification. This is where it is again, though. If they give you CMC arthritis in a young laborer, choose arthrodesis. If they give you very mild early arthritis in a very young patient that has absolutely failed non-operative care, then look for a metacarpal extension osteotomy. But for the most part, the answer is going to be trapezial resection with or without tendon interposition. How are you going to choose between those? There's studies that show that just pinning the CMC joint for 6 weeks has the same result as LRTI, although LRTI is the most common one used. Other things they're going to want you to do is assess the MP joint for the presence of hyperextension. If it's more than 30 degrees of hyperextension on the boards, you're going to want to do something, either a volar plate advancement, PB transfer. If it's more than 50 degrees, they're probably going to want you to fuse it. Other thing that's been asked is subsidence. Post-operatively, you get an x-ray and the thumb metacarpal has subsided. That has not been linked to functional loss. FCR tendonitis, splint it if that fails, inject it. Volar ganglions, you can try aspiration, but be very careful of the radial artery. That would be the structure at risk. Recurrence rates 20% versus between 5 and 10% for dorsal ganglions. Going on to dorsal wrist pain. Dorsal ganglions, remember, they come from the SL ligament. Recurrence rate of aspiration is probably higher than that, but it's been reported as 50% on one of the OITEs. 10% risk of it coming back. There's something called an occult dorsal ganglion where you can't palpate it, but they have pain there. You can best see that with an MRI scan, and the results are good with surgical excision. Slack wrist, we just talked about it. The scaphoid styloid tip is the #1 location of it. What they're going to want you to choose on this is, remember, stage 2 is the radioscaphoid fossa. Stage 3 is capitolunate. So in a stage 2, you could either do a PRC or a midcarpal fusion. For OITE purposes, lower demand, older patient, over 40, be thinking PRC. If it's under 40, the results of PRC have been shown not to be as good. So if they gave you a laborer or someone under 40, that's where I'd be looking for my midcarpal fusion. If they gave you pancarpal arthritis, of course, they get a wrist fusion. Keen box, AV end of the lunate. If they give you keen box in the overall lunate is kind of still okay, it's not just totally dissolved, then it's like short with or without a vascularized graft. If they give you lunate that's just gone, then I'd be looking for a PRC or a partial wrist fusion. The other one that comes up is keen box in a kid. In kids, be looking for temporary STT pinning. Another option would be a bridge plate. They haven't asked that, but something like that. Temporary STT pinning if they gave you a kid. Another thing, early on in keen box, there's a procedure called a core decompression, where you just drill a hole in the radius and ulna and kind of curette them a little bit. And the theory is that increases the blood flow to heal that, which simultaneously increases the blood flow to the lunate. If they give you fourth or third compartment extensor tenosynovitis, the answer is going to be look for a rheumatoid panel. Work them up for rheumatoid. If otherwise, the treatment's going to be splint and inject. Late, the treatment would be synovectomy. Remember, anatomically, the posterior interosseous nerve runs in the floor of the fourth compartment. That was asked a couple of years ago. Ulnar wrist pain.
I think we're stuck on your inbox slide here.
Oh my God, this is brutal. Do you see, is it still stuck on keen box or do you see it moving?
Keen box.
Still on keen box.
Gosh, I don't know what the deal is with this. I hate Teams. I told Olivia I hate Teams when this started. Same song, Olivia, or somebody. Share yours, we'll unshare mine.
Got it.
All right, I'll stop sharing. You want me to try again, or are you doing yours?
You can try again, Dom.
All right, I'm resharing. We back?
Yep.
This is absolutely absurd. All right, here we go. Oops. So I hope I can hide this. There's something in my screen is right in the way. I'll try to work around it because I don't want to hit it and have it screw things up. Most of these I'm going to go through. Ulnar styloid fractures. This has come up on last year's test and a few times before. Remember, if you have a distal radius fracture with an ulnar styloid fracture in real life and on the OITE, the answer is you do not need to fix it.
Gaston, we lost you.
I just texted him again.
Does anyone have a good joke?
Stop trying to steal jokes for interviews.
I didn't even think of that. I probably do need a joke.
But if you find a good one, let me know because I need one too.
I just spoke with Gaston. He's sending me his talk. I'm going to try to pull it up.
All right, gang, I'm back. I don't know what in the world. I've got like all bars on internet. I don't know what in the world is going on.
Dr. Gaston, you're muted right now.
Ah.
I was able to hear him just then.
That says, what in the world?
Only Stu can hear you.
It's just going to have to be that way. All right. Well, you want me to wait on Stu to pull it up? You think that's just safer?
Probably because your internet connection still seems pretty
Just seems to
limited.
suck totally. I'm gonna log in on my phone too, because if he's doing it, then maybe I can just talk on my phone unmuted, and it'll be better. Well, sorry,
Yeah, that
team.
could've worked. You're good. Team sucks.
Team just sucks. Okay, so let's see. I need to mute my computer now, don't I? And just talk to my phone. You getting reverb still when I do that?
Well, do you guys see my browser?
Yeah. I'm getting reverb when I talk. Are y'all getting that?
I am, but I
Sort of. Maybe just exit out of your computer. Like,
All
hang
right.
up.
Just turn the volume down on your computer and it should get rid of it.
Y'all hear me better now?
Yep.
Oh, okay, good. I can hear you good.
Yep.
Yes, dude, crank away, bud. You're on Meissner's. We got to get way down in there. Oh, there you go. You're close now. See if I can blow this up enough where I can freaking see it. There you go. Up a few. Up a few more. There you go. ECU subluxation. There we go. All right. So what you're going to do in these patients, you're going to choose initially a non-operative treatment with like Castum or something like that. And if that fails, you're going to do an ECU subsheath reconstruction. Next slide. Hamate hook fractures. They're going to give you a golfer that had a fat shot or a baseball player with a check swing. What's the X-ray view of choice that answers a carpal tunnel view? What if you can't see it on that and your suspicion is high? CT is going to be the gold standard. Treatment, if they give it to you very acutely, like the first week or so, it would be put them in a cast. But for the most part, the answer is to excise the hamate hook. What is the complication of non-operative treatment or delayed presentation? It's rupture of the FDP to the small finger. You can skip that os handles proprius. That's just bonus for somebody like Samuel that just loves it. All right. TFCC, anatomy. Remember the deep radial ulnar ligaments, also known as the ligamentum subcruentum, are the most important stabilizers of it. We can go next slide. Types of TFCC tears. Just remember there are two main types, traumatic and degenerative. For your traumatics, just treat it exactly like the knee meniscus. So peripheral tears, you're going to fix. Central tears and other tears, you're going to debride. For the degenerative tears, you're always going to debride them. And it's just a matter if they have other things or not that you have to address simultaneously. Next slide. If they give you a patient with a TFCC tear and they're ulnar positive, strongly consider shortening the ulna at the same time. If they give you a tear that they say you scope the wrist and the TFCC has lost its trampoline effect or doesn't have its normal trigger, that's when you worry about an avulsion of those deep foveal fibers, the ligamentum subcruentum or the deep radial ulnar ligaments. Those would need a repair to restore the stability of the wrist. Next. When you scope a wrist, things that are at risk. Whenever you see a 1-2 portal or a 3-4 portal, that means it's going between the first and second compartment or between the third and fourth compartment. So if you think about what lives between your first and second compartments, it's your radial sensory nerve and your radial artery. So those are what are at risk. A 3-4 portal, where is it made? It's 1 centimeter distal to Lister's tubercle. Next slide. Skip that. More than you need to know. Pisiform, how do you see the pisiform on x-ray? A 30-degree supinated view will give you a perfect lateral, and a carpal tunnel view is going to give you a perfect axial. And then anything on the OITE with pisiform is going to be non-op, and then if it fails, take out the pisiform. Carpal instability is a big topic to cover in this, so I'm going to give you guys this. You can look at these slides later if you want to learn more, but here's what you're going to remember, especially for the juniors taking OITE. The scaphoid always flexes. The triquetrum always extends. The lunate goes with whoever he's still attached to. So if you tear your SL, the scaphoid's going to flex, the triquetrum's going to extend, the lunate's attached to the triquetrum, so it's going to extend along with it. Scaphoid flexion with lunate extension is what's called a DZ. If you tear your LT, scaphoid's going to flex, and the lunate's still attached to it, so it's going to flex with it. And the triquetrum's going to extend. The lunate and the scaphoid flexing is called a VZ. Tears within the row, like the proximal row, like an SL tear, is called a carpal instability dissociative, meaning there's a dissociation of that row. Carpal instability non-dissociative would be like mid-carpal instability, where it's between the proximal and distal rows. Next slide. So DZ is most commonly caused, like I said, by an SL tear, but there's other things that can cause it more than you really need to know. If someone has an acute SL tear on OITE and they're young, the answer is going to be fix it. If they're older or have arthritis, we would do more salvage things, and I don't think they're really going to ask that, so we'll go next. This is what a VZ looks like. We see the scaphoids flexed and the lunates flexed. So fair game, and it's been asked, is what structure is most likely injured? It's an LT ligament, but it's also been asked, an isolated LT ligament tear will not give you a VZ. You have to tear the secondary stabilizer. So to get this would be an LT plus radiolunato-triquetral or dorsal radiocarpal ligament. Answer acutely would be fix it. Answer delayed would be either a reconstruction or an LT fusion. Next. So carpal instability non-dissociative. The things that have been asked recently is mid-carpal instability. So midcarpal instability, they're going to give you a young, ligaminously lax female who her wrist clunks as she moves from radial to ulnar deviation. The answer is going to be non-op. The actual splint is something called a pisiform boost splint. And it would have to be that really failed to get pushed to surgery. So really look for non-op, midcarpal instability, young female. Other things they've asked are what are the different wrist ligaments. We talked about the volar ones early. Dorsally, you got the DRC, dorsal radiocarpal, and the DIC, dorsal intercarpal ligaments. And then the volar wrist ligaments, one more time for you: radioscaphocapitate, long and short radiolinate, and then the ulnar carpal ligaments. Next slide. Let's run through the different arthritises that they like on OITE. So hit them. Next slide. For osteoarthritis, things they like. This extra, all you need is this picture. This is a mucus cyst. The answer is non-op if it doesn't bother them, or if it does, you're going to go excise the cyst plus take off the osteophyte. So osteophyte excision needs to be part of that. PIP and DIP arthritis, for the most part, you're going to fuse them. If they ask you for arthroplasty, it's pretty much going to be ulnar digits that has good preoperative range of motion, but they're going to give you fusion is better for stability. Next slide. Psoriatic arthritis, classic x-ray findings are pencil and cup deformities. They gave this exact x-ray and asked you what's the diagnosis, and you should be able to look at those pointy little pencil and cup deformities and know it's psoriatic arthritis. They've also asked that the skin findings precede the arthritic findings, and those skin findings are plaques and pruritic scaling. And the answer would be medical management, and if that fails, arthrodesis. Next slide. Rheumatoid arthritis of the elbow, things that have been asked. Early on, what's the role of synovectomy? It improves motion, but does not change the long-term disease. Late rheumatoid, they're going to want you to do a total elbow. Next slide. Rheumatoid wrist. Bear in mind, problems they get are what's called Caput-Ulna syndrome, where the DRUJ gets synovitis, then you get dorsal displacement of the ulnar head, and then you start getting tendon ruptures, which are known as von Jackson syndrome. If they give you Caput-Ulna in a patient that's with rheumatoid, the answer is going to be a DERA or possibly a Suave-Capangeli. If they give you a von Jackson syndrome, the most common tendons, the EDQP, treatment's going to be address the ulna with either a DERA or an SK, and then reconstruct your tendons. We already talked about how to differentiate those other things. RA for the hand. For the wrist, the most stable long-term solution is a wrist fusion. Arthroplasty has a high complication rate, but patients who have had both fusion and arthroplasty do prefer the arthroplasty, and it does obviously maintain some motion. Tendons, basically, if they have tendons that have ruptured, you're going to repair or reconstruct them. Next slide. MP joint deformity is from synovitis. Really, the only things they're going to ask, if there's no arthritis at all and they just have this deformity and it's bothering them functionally, they're going to want you to do a synovectomy with extensor centralization. If they have that plus arthritis, you're going to add an arthroplasty. Next slide. Gout, remember, it's uric acid that's elevated in gout. It's negative birefringent needles. It's monosodium urate. They get punched out erosive lesions on both sides of the joint. You can also have superinfected gout, so be looking at your cell count from aspirates to help you differentiate that. Obviously, medically manage them, and late you might do a fusion. I already talked about it. Calcified TFCC, remember CPPD and pseudo-gout. Lupus, this is a sneaky one. When they give you lupus on the OITE, think about them as like a ligaminously lax algorithm patient. So same thing for like Ehlers-Danlos. If they give you a lupus and Ehlers-Danlos patient with CMC arthritis, your answer is going to be a fusion. So you don't want to be looking for soft tissue reconstructions in lupus or patients with Ehlers-Danlos. The x-ray on the right was tested in the past. What's the diagnosis? Remember, scleroderma can be associated with Crest syndrome, which is calcinosis, and that's what that calcinosis is. Sympathectomy can provide some short-term relief. Next slide. Dupuytren's. Big topic. Here's just buzzwords to remember. The offending cell is the myofibroblast. Inheritance, autosomal dominant. What does a spiral cord do? It displaces the neurovascular bundle in two directions, palmar and central. The other cords that have been asked, remember,
The natatory cord is what adducts the fingers and runs transversely between fingers to contract them that way. The retrovascular cord is what gives DIP contractures. Also, they've asked all the following are involved except, the answer for except is going to be Cleland's ligament because it's more dorsal, although in reality it usually is involved, but for the OITE it's not. Treatments, they could even give you needle aponeurotomy, which would give you the fastest recovery. They could give you collagenase, which is a non-operative treatment that's also approved, which I think is on the next slide, or they can give you partial fasciectomy. Next slide. Xiaflex, also known as collagenase, it's FDA approved. Indications are a palpable cord with more than a 20-degree contracture. Negative for OITE is expensive. Other negatives for OITE is the risk of flexor tendon rupture and the risk of an allergic reaction. Next slide. So I don't know how they're going to use collagenase other than that, but those are the ones I remember. Tendon transfers. Go to the next slide because I think a lot of this is intuitive, but I'll tell you the way to approach OITE tendon transfers is if you just know anatomy and you ask yourself what's out, what's available, and what's needed. And then balance, is this a power transfer or a positional transfer? So if you take something like opposition, all you're doing is pulling your thumb out of the plane of the palm. So you're not going to choose something like FCU. That's an absolute behemoth wrist flexor to do that. So you're going to look for something little like EIP or palmaris. If you're looking for something like wrist extension, well, that one we'll get to later, but you're going to need something stronger. So let's go to the next slide. Radial nerve palsy. The one for OITE to remember is wrist extension. You're always going to choose pronator teres to ECRB. If you know that, pronator teres to ECRB, if you can just remember that, then you're already down to probably the right answer or just two. And then for finger extension, you're either going to use FCR, FCU, or FDS. And for thumb extension, it's small, so you're usually going to use either palmaris or an FDS. Remember, I already talked about for distal radius fracture, you're going to use EIP to EPL transfer if the EPL ruptures. Obviously, you can't do that in radial nerve palsy because EIP is not working. Other questions that have been asked in a radial nerve palsy with a humerus fracture, what's the first muscle that's going to recover? Or what's the next muscle that's innervated by it? Brachioradialis, and that's the answer. And then differentiating a radial nerve palsy from a PIN palsy. Remember, PIN palsy, you're still going to have ECRL innervated, so they're going to have wrist extension with radial deviation. They're just going to lack digital and thumb extension. Next slide. Opposition transfers. These do get asked because there's some classics. The most anatomic is an FDS ring using the pisiform as your pulley. So that's been asked. The pisiform is your pulley. If they give you a patient with severe carpal tunnel syndrome and complete thenar atrophy, the answer to look for is what's called a Kamitz transfer, which is just moving palmaris over to the APB, and that's because you're already doing carpal tunnel release and you're right on top of palmaris. In a congenital case that you want to add bulk, you're going to choose the Huber transfer, which is the abductor digiti quinti. And if they give you a combined median and ulnar nerve palsy, you're going to choose the EIP since it's one of the only things left working. Congenital. Too much to cover, so I'm just going to hit the hugest highlights. Limb bud appears in the 4th gestational week. Digital separation, week 7. Apical ectodermal ridge controls the longitudinal growth of the developing limb. So if you injure the apical ectodermal ridge, you're going to have a transverse arrest of the limb. The zone of polarizing activity, ZPA, is what gives ulnar radial orientation. And that's what can lead to like duplications and absences. Next. Most common congenital anomaly is syndactyly. Number 2 is polydactyly. And then we've got the classification of all these different things. I'm just going to hit the highlights, so roll through them. Failure of formation can be a transverse, which is like amelic, like nothing's there, or longitudinal, where you're missing like half of it, like radial longitudinal deficiencies. Phocomelia, where you've got like a hand, but you're missing it in between, like a little baby over there. That was that whole crisis over in Europe, obviously, when we had drugs that weren't approved here for deliveries. Transverse arrests are typically non-syndromic. One fun one that's come up on OITE is what's the treatment of choice for blind bilateral amputees? And it's this Krukenberg procedure, and I tell it every year to you guys. If any of you guys can find me a blind bilateral amputee that needs a Krukenberg, I will take you and any friend you want out to the nicest steak dinner that they have to offer in Charlotte, because I'm dying to do one. Aside from that, kiddos, go back one side real quick. Kiddos, when should you put them in a prosthesis? Just remember, fit when they sit. So between the ages of 6 and 9 months, you're going to put them in a passive device. Next slide. Radial longitudinal deficiency. The number one thing to remember with this is these kids, other things form at the same time that can be deadly. So remember, radial longitudinal deficiency, consider TAR syndrome, which is thrombocytopenia absent radius. So you need to know their platelet count. Holt-Oram, which is heart anomalies. Fanconi's anemia, which is obviously a pancytopenia, which you would assess with a chromosomal breakage test. And then Vater syndrome. The involved gene is that sonic hedgehog. And then remember, it's been asked before, they'll show you a patient with radial longitude, so no radius, but they have a thumb. That is TAR syndrome. That's your answer, because that's all the other ones usually don't have a thumb. Treatment is you centralize them around the age of 6 months, and then we do their thumb reconstruction after that. Big important thing, if their elbow doesn't work good, then do not do wrist, because otherwise they have a hard time getting their hand to their mouth. Next slide. Cleft hand. Basically, OITE doesn't ask you much about this. If they do, the answer is going to be close down that cleft. So some surgery to remove the cleft. Next slide. Yep, we'll run through these. Next slide. Radial ulnar synostosis from the OITE, if it's unilateral, you do nothing. If it's bilateral and they're in reasonable position, you do nothing. The only time you would do anything is if they had bilateral and they were like both really supinated or something, you do an osteotomy to put the dominant side in slight pronation and the non-dominant side in slight supination. That way they can write with their dominant, wipe their butt with non-dominant. Next slide. Synphalangism. This is when kids can't move their PIP joint. It tends to be associated with Apert's, brachydactyly, and Poland's. Treatments, observation. Very rarely an osteotomy. Camptodactyly. They're going to give you this picture or some picture like it. It's going to be a PIP joint deformity in flexion, and they're going to ask you what is the etiology. For the purposes of OIT, abnormal lumbrical insertion. In reality, there's a ton of different things, but that's always the board answer. Treatment, stretch and splint, very rarely surgery. Clinodactyly is a coronal plane malalignment. Typically, they'll have a delta phalanx. Observation, unless it interferes with function, and then it's going to be either an osteotomy through the delta phalanx or excising the delta phalanx if it's like a little bitty thing. If they give you the small finger P3 and it's this funny looking curve P3, the answer is that's Kerner's deformity, and it's osteotomy when it's big enough. If the thumb is flexed, if it's the IP joint flexed, then it's a congenital trigger thumb. Wait until they're at least a year or two old, stretching in the meantime. If that fails, surgery. If you do surgery, structure at risk is the radial digital nerve. If it's the MP joint that's flexed, that's called a clasped thumb. It's usually an EPL deficiency. Treatment would be an EIP to EPL transfer. Also, don't forget the diastrophic dysplasia. Those little dwarfs get the hitchhiker's thumb. That's the classic thumb associated with them. Next slide. Syndactyly, again, number one problem. It can be simple, which is skin only. Complex, which involves bones. Complete to the end of the finger. Partial, not to the end of the finger. Half or bilateral. Acrosyndactyly is where the distal parts stuck together, but proximally there's a little window or fenestration. That is by definition amniotic band syndrome. Most common syndactyly is ring and small finger. What limits how proximal you can make the web? It's the bifurcation of the artery. And then the number one late complication is web creep. Poland syndrome, absent of the pec on that side, the pec major, and then they'll have unilateral on that side symbrachydactyly. So think Poland's, absent pec major, sternal head, unilateral symbrachydactyly. No real treatment typically. Preaxial, so they give you duplicate thumb. Things to know, the most common type is a type 4. And in terms of remembering the classification, it's really easy. Split distal phalanx is type 1, 2 distal phalanxes, type 2. Split P1, type 3. So basically, as you march down and split and divide, you add a type. So you get to type 7, which is triphalangeal. That's the only type that's inherited. So type 7 would need a genetic workup. The other types wouldn't. Next slide. This is just a cool thing just to see, so I put it in there. This is mirror hand ulnar dymelia. They won't ask you much about it, but it just makes a cool picture. Macrodactyly, pearls on this. They have an associated what's called lipofibromatous hamartoma of the digital nerves and or the median nerves. These kids can get carpal tunnel secondary to the lipofibromatous hamartoma changes. Treatments, so there's two kinds. If the finger like this kid's is kind of bigger than it should be, but it's not like clown silly, then it's going to be wait till it gets the size of the parent's finger, and then at that time, debulk in epiphysiodesis. If they give you one that's like a clown hand and it's ridiculous, then the answer is amputation. Next slide. Thumb hypoplasia. So now instead of too many thumbs, we've got a little bitty thumb. Very simple for OITE. If the CMC joint is unstable or there is no thumb, then the answer is index pollicization. If you have a stable CMC joint, then you're going to choose the option that's reconstruction. If they want you to reconstruct it, there's three things to look for. Tendon transfer for opposition, first web space release, and MP joint stabilization. Next slide. Congenital radial head dislocations. What they're going to give you is a kid that comes to the ER because like they fell off a swing, and they're going to want you to look at these x-rays and recognize that the radial head is convex rather than the typical concavity, and that the capitellum looks hypoplastic. The answer is going to be simple observation. Do not choose surgery for this. It's often bilateral. Madelons, all they have to do is give you this x-ray, and you have to know that's Madelons just looking at it. You see that hyperradial inclination, that volar ulnar corner looks weird. So it's volar ulnar physeal arrest. What's attached to that piece? It's called Vickers ligament. Treatment, if it's asymptomatic and minimal, is going to be just observation. If it's bothering them substantially, they're going to be looking for an osteotomy. Constriction band syndrome. What they're going to want you to do surgically is Z-plasties with resection of the underlying contracture. If they give you a really bad one, they'll want you to do it in 2 stages. Otherwise, you can do it in 1 stage. Slide. Cerebral palsy is a lot to get into. Basically, for at least upper limb CP, and I don't know what the PEDS people will tell you, just know the classic deformity. Shoulders internally rotated and they basically look like a stroke patient. Internal rotation, adduction, elbow flexed and pronated, wrist flexed and ulnarly deviated, thumb and palm and swan neck deformities. Look for splinting, therapy, Botox as your primary go-tos. How does Botox work? Has been asked. Remember, it's a reversible block of the acetylcholine receptors at the neuromuscular junction. You're only going to choose surgery as a last resort in these cases. You can skip this because I really don't think they're going to give you surgery on a CP kid upper limb. So you can just roll through these. Anyone that wants to see what they are. All right, we're at the very end too, just so y'all know, there's only like 3 more slides. So high yield tumors. Glomus tumor they love. Triad of pain, cold intolerance, and focal tenderness. It's going to be intense on T2 on your MRI, and the treatment's going to be marginal resection. Epidermal inclusion cyst, they're going to tell you a patient got penetrating trauma and has an enlarging mass. As long as it doesn't have like a pulsatile thing where you think it might be a pseudoaneurysm, it's going to be an epidermal inclusion cyst. Answer marginal resection. Other ones. The picture on the top right, all they have to do is they showed that picture before. What is it? It's a pyogenic granuloma. Treatment would be either they might want you to do silver nitrate initially or just remove it. Then we hit all the number ones. What's the number one cause of acrosyndactyly to the hand? It's going to be lung cancer. What's the number one malignant lesion of the hand? Squamous cell carcinoma. What's the number one bone malignancy of the hand? It's chondrosarcoma. What's the number one primary malignancy overall? Primary sarcoma overall of the hand. It's epithelioid sarcoma. And every one of these has been asked, by the way. What's the most common benign phalangeal bone tumor? It's an enchondroma. What's the treatment of an enchondroma? Curettage and bone graft. And then they'll also ask you, what if you see a patient with a subungual streak, like a melanotic streak, particularly if it's a white person? The answer is going to be a biopsy. And what if it is subungual melanoma? The most common treatment is going to be IP amputation, unless they give you something like very low grade, mild atypia, then they may want you to try to salvage it, which is kind of resection and grafting. I think we got one more. Oh no, is that it? It's the finale. Y'all had enough? I can't hear anybody, so hopefully y'all just
That
have a
was
great
fantastic.
enjoy.
Thank you, Dr.
Awesome.
Gaston.
Full run. Sorry for all the technical problems there, but I think we made it through it. Any questions? I know it's a ton to cover. All right, then I guess everybody go enjoy their night.
Thank you.
Dr. Gaston.
You bet.
Thank
See
you,
guys.
Dr.
Thank
Gaston.
you.
Absolutely. Take care.
Yeah, PGY2s. I'll see you on the test
Thank
taking
you.
strategies here in a minute.
Are we saying on this, or is there